Good morning and welcome to the cardiovascular health stream of the Ngar-wu Wanyarra Aboriginal and Torres Strait Islander Health Conference. My name is Luke Burchill. I'm a proud Yorta Yorta Judge Algarang man and lead of the Cardiovascular Health Equity Group at the University of Melbourne. It is with particular pride that I stand here today on Yorta Yorta country. I'd like to acknowledge the Yorta Yorta people as the traditional custodians of this land and pay my respect to elders past, present and emerging, and also feel the presence of my ancestors, our ancestors, guiding us through the work that we do, the conversations that we have each and every day. I work with a dedicated team of clinicians, scientists, biostatisticians, epidemiologists and health economists, all with a shared commitment to improving the functionality of administrative health services data for Victorian Aboriginal nations. We have linked data from primary care to hospital so that we can understand the healthcare journeys of our people, of our mob. We do this so that we can improve access to care, treatment and outcomes for Victorian Aboriginal people who for too long have been missing on the map. This is our way of pushing back against terra nullius as it relates to Victorian Aboriginal people in health services research. Sit back and enjoy. We welcome your questions. Thank you.
Good afternoon, everyone. My name is Eloise Price, and I'll be presenting on understanding the characteristics of Victorian cardiovascular disease, hospitalisations and care using linked health service data. Both Aboriginal and Torres Strait Islander people are represented within this dataset, and therefore, throughout the presentation, the term Indigenous will be used respectively hereafter to encompass both Aboriginal and Torres Strait Islander people. I'd like to begin my talk today by framing the perspective I bring to this study. I have grown up on Larrakia land in the Northern Territory and recently moved to Wurundjeri Woi-wurrung land, where I've lived and worked since. The rich and diverse Indigenous culture of the land in which I was raised has influenced me personally and taught me respect, integrity and compassion for Aboriginal people and their shared rights and values. I would also like to acknowledge and pay my respect to the traditional custodians of the lands in which we are all calling from today, as well as the Victorian Aboriginal nations most heavily represented within this dataset, that is the Tongwurrung, Woi-wurrung and Wathaurong nations. There are currently just over 60,000 people who identify as Indigenous in Victoria. Each one of these individuals has their own story connected to a nation that is rich with history and culture. Therefore, it is our responsibility to be aware of how we present our data and how this will be perceived by those it represents. I would also like to acknowledge a history of Indigenous research in which data can be divisive. Colonisation of Australia has resulted in ongoing devastation, dispossession and oppression for Indigenous people. The results of colonisation had led to a huge health disparity between Indigenous and non-Indigenous Australians. Over the past decade, research and government policies have identified the need to improve the state of Indigenous health. In order to do this, it is crucial to understand the health status of all Indigenous Australians. However, despite the significance of accurate statistical representation in health research, national reports from the Australian Institute of Health and Welfare have often admitted Victorian Aboriginal cardiovascular disease data as deemed inadequate. Exclusion from these reports ignores the experience and voice of Indigenous people and has resulted in a large gap of knowledge and data. This is a huge concern as cardiovascular disease is one of the largest contributors to the health gap between Indigenous and non-Indigenous Australians. Underrepresentation in health service research can have a significant impact on funding. Limited funding in this area limits the potential to implement policy change to ultimately make a difference in closing the gap. Therefore, it is crucial that Indigenous Victorians are represented in health service datasets. Ultimately, health equity is at the very heart of closing the gap and is defined as the absence of socially unjust or unfair health disparities. A shifting focus towards achieving health equity requires Victorian Aboriginal cardiovascular people to be identified within Victorian health service datasets. Collecting adequate health service data in which Indigenous Victorians are recorded is a crucial step towards reducing the gap in knowledge surrounding Victorian Aboriginal cardiovascular events and outcomes. It will allow us to address the inequities that exist between Indigenous and non-Indigenous Australians and help to improve Indigenous cardiovascular health outcomes. Data linkage has emerged as an important tool for linking administrative datasets and has the advantage of being able to reach underrepresented and hard to reach populations. In this context, it can provide a new opportunity to understand Victorian Aboriginal cardiovascular health outcomes as part of addressing the knowledge gap. As demonstrated here, data linkage involves data being collected at the time of a health or life event. Unique codes are created for each patient, and personally identifiable information is removed. And this is how you come about a linked health service dataset. Therefore, the questions grounding this research are, what are the characteristics of Victorians presenting with cardiovascular events, and do they differ by Indigenous status? If there are differences in Indigenous status, I'll explore whether they are based upon age, gender, remoteness classification, or socioeconomic disadvantage. Identifying these differences may be able to inform public health interventions to improve outcomes. This is a retrospective observational study. My population of interest is adults over the age of 18 who presented to the Royal Melbourne Hospital, the Western Hospital, and the Northern Hospital with cardiovascular events between the years 2011 and 2019. The dataset is a linked health service dataset involving these three hospitals. The data sources that we used were the Victorian Admitted Episodes dataset, which collect data on each admitted patient episode, and the Victorian Emergency Minimum dataset, which collects information on emergency presentations at Victorian hospitals. The VAED and the VEMD have strict protocols in place to ensure risk to individuals are minimised. The data sources have been linked using BioGrid Australia. BioGrid is a data connectivity resource and research service that is highly committed to protecting the security of data it manages and the privacy and confidentiality of patients who are represented in the data. In this study, outcomes of patients were defined by cardiovascular events, which are identified in the VAED and the VEMD using Australian modified ICD-10 codes for the following conditions. To determine the characteristics of the population, analyses were performed on the following variables. The IRSD summarizes a range of information about the economic and social conditions of people living within certain areas. Overall, 84,383 individuals presented with a cardiovascular event. 35.4% presented to the Royal Melbourne Hospital, 39.5% presented to the Western Hospital, and 25.1% to the Northern Hospital. The median age at first presentation was 71 years, 58% of cases were males, and coronary heart disease was the most common type of cardiovascular event people presented with. We also looked at the percentage of individuals who had a cardiovascular event by socioeconomic disadvantage in the overall population. As I mentioned before, IRSD quintiles are a measure of socioeconomic disadvantage, with 1 being most disadvantaged and 5 being least disadvantaged. Overall, a higher proportion of those who lived in areas of socioeconomic disadvantage presented with cardiovascular events. Overall, 85% of Victorians presenting with cardiovascular events lived in major cities. We sought feedback from Aboriginal hospital liaison officers from the hospitals involved in this study. They provided feedback that their first priority would be to understand how people who identify as Indigenous are represented in the dataset. We responded to this by then exploring the characteristics of Victorians presenting with cardiovascular events by Indigenous status. Firstly, we looked at the age at first CV event. I would like to highlight here on the y-axis that this is the age of a person's first cardiovascular event that appeared in the dataset. It must be acknowledged that people may have had a cardiovascular event that occurred prior to the start of this study. However, I did not have access to this data. In the Indigenous population, there were 881 people, and the median age at first presentation was 60 years. This was significantly younger than that of the non-Indigenous patients, where we had a much larger sample size of just over 82,000. Overall, 25% of the Indigenous population were less than 50 years old, compared to 11% in the non-Indigenous population. Given Indigenous Victorians were most likely to present at a younger age, I then wanted to determine the types of cardiovascular events that they were presenting with. This graph shows the types of cardiovascular events on the x-axis and the percentage of those with a cardiovascular event on the y-axis. Coronary heart disease was the most common event Indigenous people presented with, as seen in the light blue, followed by stroke, congestive heart failure, and peripheral vascular disease. These trends were similar in non-Indigenous Victorians in the navy blue and reflect national studies with coronary heart disease being the most common type of cardiovascular event and the leading single cause of death burden in Australia. Within the types of cardiovascular events that patients presented with, I then looked at a breakdown of gender to determine whether males or females are more likely to present with different types of cardiovascular events. Males are depicted in the navy blue and females in the light blue. Indigenous males were more likely to present with coronary heart disease and peripheral vascular disease than females. There was a similar trend in non-Indigenous patients for coronary heart disease, stroke, and peripheral vascular disease. In the Indigenous population, there was a small observed difference in the proportion of males and females presenting with congestive heart failure, with more females presenting than males. However, in the non-Indigenous population, these proportions were quite similar. Given there was no major difference in the breakdown of gender within each cardiovascular event type by Indigenous status, I then wanted to determine whether there would be any differences according to socioeconomic status. As I mentioned before, IRSD quintiles are a measure of socioeconomic disadvantage, with 1 being disadvantaged and 5 being least disadvantaged. This graph shows that a large proportion of people presenting with cardiovascular events lived in areas of social disadvantage. This was true for both Indigenous and non-Indigenous people, although Indigenous people in the light blue were more likely to reside in areas of lower socioeconomic status. Given people who presented with cardiovascular events are more likely to be from areas of disadvantage, I then wanted to know whereabouts in Victoria they were presenting from by looking at their remoteness classification. Not surprisingly, most people admitted to the 3 hospitals lived in major cities. What was interesting though, was that a higher number of people, of Indigenous people, again in the light blue, from inner regional and outer regional Australia presented to these tertiary centres, suggesting that these urban hospitals are important for providing specialist care to Indigenous Victorians from rural communities. Remote and very remote were combined due to having very few numbers. After identifying differences describing the characteristics of Victorians presenting with cardiovascular events by Indigenous status, the Indigenous population was then explored by itself to determine whether these differences were according to a range of characteristics. Among Indigenous people represented within the dataset, there are observed important differences in cardiovascular events according to their event type, age, and gender. Looking at those who presented with congestive heart failure, a larger proportion of females presented in almost all age categories. However, these differences were not statistically significant. Of those who presented with coronary heart disease, 21% were less than 50 years old. A larger proportion of males presented in almost all age categories. The difference was most noticeable in the under 50 years old, of whom 75% were male. A similar trend was observed in males and females presenting with peripheral vascular disease. And there was no significant consistent difference in the age and gender of those presenting with stroke. Given we observed differences in both socioeconomic disadvantage and age, I then wanted to further explore this within the Indigenous population. This graph shows the level of socioeconomic disadvantage on the x-axis and the age at first presentation on the y-axis. As you can see, Indigenous patients who resided in areas of most disadvantage were most likely to present at a younger age than those who resided in areas of least disadvantage. The median age at presentation in those who lived in areas of most disadvantage was 58, compared to 65 in those who lived in areas of least disadvantage. So to summarise, what we found was that Indigenous Victorians were presenting at a younger age than non-Indigenous Victorians. Coronary heart disease was the most common type of cardiovascular event, with a large proportion of young males presenting with this disease. A large proportion of people presenting with cardiovascular events lived in areas of social disadvantage. Within the Indigenous population, those living in areas of social disadvantage were presented at a younger age. The readings for these findings are multifactorial and complex. It has been well established that certain modifiable risk factors related to social disadvantage may precede the onset of cardiovascular disease by many years. This study provided new insights surrounding the cardiovascular data and care needs for Victorian Aboriginal communities, in particular, highlighting that a high proportion of young Indigenous males were presenting with coronary heart disease. These findings have implications for healthcare policy and can be used to inform public health interventions to reduce cardiovascular events and their adverse clinical outcomes. This project will also serve as a foundation for future research that aligns with community concerns, needs, and priorities for cardiovascular health and well-being. Thank you everyone for listening. I'd like to thank my team and BioGrid Australia, as well as the Aboriginal hospital liaisons. Thank you.